Not a... Thank you, Julie, for pressing that record button. Dr. Berlin, okay, you're now a co-host. You can share your screen in a minute. Dr. Berlin is the chair of the Department of Psychiatry at Stanford Health with advanced training in child and adolescent psychiatry and clinical expertise with college students, which is most relevant to tonight's presentation, among many other groups. Please remember that this presentation is not providing individual medical healthcare advice. If you find it helpful, bring the information you learned tonight to your clinical team to confirm that it would work with your loved one. And please let me turn it over to you now, Dr. Berlin.
All right, let me share my screen and then let's get started. All right, can everybody hear me okay? Fantastic. So I'm going to be talking about borderline personality disorder in young adults. I'm going to start the presentation by reading through a case of a patient of mine that I think really illustrates a lot that we'll then flow into talking about for the rest of the conversation. I'm going to then, after talking about the case, I'm going to talk a little bit about college mental health more broadly. And will use the term college student and college mental health and young adult mental health interchangeably, although obviously I recognize that not all young adults are in college. But what I'm really referring to is the 18 to early 20s age group. And that's mainly what I'm going to be focusing on throughout this talk. And then I'm going to get into borderline personality disorder. I'm going to talk a little bit about what it is, how it manifests, some ideas about how to help treat the condition, and then also what families can do to support loved ones who have the condition. And we'll hold all questions, I guess, for the end of the talk. And let's get started. So I do want to start with just a trigger warning that the talk will include a discussion on the topic of suicide and self-harm. Please remove yourself from the conversation if the content becomes too distressing. All right, so let's talk about Allison. So I'm actually going to just tell someone right outside my office to quiet down for a second. I need you to keep your... All right, my office is right in the thick of, right outside of a patient area, so wanted to make sure folks were being quiet out there. All right, so Allison is a 19-year-old sophomore at a high-achieving liberal arts college in Connecticut. She lives on campus during the school year and home with her family in Fairfield County during summers, when she also works full-time as a camp counselor for special needs youth. She's majoring in psychology and used to want to be a therapist, but now just feels lost, confused, and empty inside. She is a gifted artist, loves to read nonfiction, and participates in theater at school. She has seen therapists and psychiatrists on and off since she was 7 years old and has been given various diagnoses, including ADHD, anxiety, eating disorder, depression, impulse control disorder, cannabis use disorder, and bipolar disorder. She has struggled with depression, worthlessness, frequent mood swings, poor self-esteem, and suicidal thoughts, in quotes, all my life. And she self-injures by cutting with the razor, in quotes, because it's the only thing that distracts me from negative thoughts about myself. She also smokes cannabis throughout the day to numb the pain. She has impulsively slept with more than 12 partners at school this semester because, in quotes, I want people to like me and I want to feel loved. When asked about a trauma history, she says, in quotes, I'm not sure. In 10th grade, I was forced to do some things with a group of local college boys at a party, but I was leading them on and kind of deserved it, end quote. She worries all the time that the people she cares about will abandon her. She feels this way because, in quotes, I don't know how anyone could love me. I'm gross. She once took 15 tablets of Advil when she was in a fight with her boyfriend senior year of high school because, in quotes, I needed to show him how much he hurt me when I found out he was talking to another girl. She was brought to the emergency room that time and 3 other times when she threatened to jump from the roof of an office building. She was once psychiatrically hospitalized, but, in quotes, all they did was lock me up and tell me I needed to take medicine to get out. The hospital was disgusting, so I lied to tell them. I lied and told them I felt happy, and they let me go in 3 days. She has tried 5 or 6 different psychiatric medications, but nothing helped, and they upset her stomach, so she stopped taking them. When asked about her parents, she says, in quotes, "They are nice people. They work hard and want to give me a good life, but they don't get me at all. They're old school and just tell me to snap out of it and stop being a drama queen. My mom yelled at me when I got hospitalized because it was an embarrassment to the family." All right. So why is it important to highlight the topic of mental illness in college students and young adults? So in psychiatry and medicine more broadly, patients are often bifurcated into pediatrics and adults. But we know that the college years, the transition from adolescence to adulthood, is unlike any other time and comes with its unique circumstances and challenges. This is especially true for our college students today. Just think that our college students ages 18 to 22 were actually 13 to 17 years old when the world shut down in the spring of 2020 due to COVID-19. This was enormously disruptive to their development. This is also the first generation that grew up with social media as a mainstay and mostly without restrictions. And of course, they're coming of age with the numerous societal issues of our time: racial violence, gun violence, global warming, geopolitical crises, including the wars in Ukraine and the Middle East and its impact on college campuses, political extremism and violence, anti-LGBTQ movements, cancer culture, and on and on. Among college students, 36% have been diagnosed with anxiety and 30% have been diagnosed with depression. Suicide is now the second leading cause of death for teens and young adults ages 10 to 34, and that's after accidental accidents as the number one cause of death. 13.6% of adults aged 18 to 25 had serious thoughts of suicide in the past year. What are some of the mental health challenges faced by college students? So the transition between adolescence and adulthood is a challenging period to navigate emotionally, and many of our severe mental illnesses first manifest in this period. For example, this is the most common time to see first episodes of schizophrenia and bipolar disorder. It's also a time of heightened substance experimentation, which can lead to substance use disorders. And unfortunately, it's also a time of increased exposure to trauma that can contribute to many psychiatric illnesses, including PTSD. It's also an age where we see higher rates of anxiety, depression, suicidality, and self-harm. There is often confusion and stress that comes with increased independence, identity formation, finding new friends and intimate partners, etc. And all this is happening while the human brain does not fully mature until age 26. The way that the brains of college students are wired leads them to think and behave more impulsively without pausing to think through the potential consequences of their actions. What types of mental health resources are available to college students? This is really a great question and one that often goes overlooked when students and parents are making their college choice. Most colleges and universities have some level of mental health support offered through their student wellness services. But the truth is that there is enormous variability in how comprehensive the mental health services are on any given campus. Services range from some schools that have only crisis support to other schools that have many full-time employed mental health clinicians, including psychiatrists and psychologists, to provide specialized care. Some schools even provide free care where students do not have to use their insurance or have their insurance billed, so that no notices are sent home to parents. This allows a student to access care privately if they choose. I really encourage the parents of any high school student with mental health challenges to research the level of psychiatric support at the schools they are considering. Here in Stanford, any college student who receives their medical care at Stanford Health can be referred to our new outpatient behavioral health office at the Tully Health Center, where they can receive psychiatric medication management and psychotherapy. Not enough young people are getting support for their mental health. Only 42.7% of young adults aged 18 to 25, 42.7% of young adults aged 18 to 25 perceived an unmet need for mental health services. And 72% of LGBTQ plus identified teens and young adults desired professional counseling, but only 32% were able to receive these services. Schools should do more to support student mental health and suicide prevention. In fact, 91% of school administrators feel that schools should make more efforts to provide suicide among their students. So when should a college student consider taking a mental health leave of absence? This question ultimately comes down to how well a student with mental illness can function at college. The goal is to try everything possible to support the students so that they can stay on campus and stay in school. It's very important for young adults to have structure, maintain a routine, be around peers, and continue to be challenged academically. Taking a leave of absence is the last resort when a student simply cannot appropriately function socially, academically, or emotionally. We don't want students failing out of school due to their mental health problems, which will only exacerbate their difficulties. The last thing I will say on this topic is that when a student does have to take a leave of absence, we don't want them sitting around all day at home without any purpose or meaning. To the extent possible, we encourage them to work part-time, volunteer, help around the house, or take online classes. College students don't tend to do well when they are idle for extended periods of time. All right, so what is borderline personality disorder and how does it impact college students? Although borderline personality, or BPD for short, is the clinical name, my actual preferred name for the condition is emotion dysregulation disorder because it better describes the condition. Persons with borderline personality disorder are more emotionally sensitive, more emotionally reactive, and have a harder time returning to baseline when emotionally triggered and under distress. In order to be given the diagnosis, you need to have at least 5 of the 9 qualifying symptoms that I'll go through in just a second. But it's important to acknowledge that this is a serious and life-threatening condition. BPD accounts for at least 500,000 visits to emergency departments each year in the United States, and at least 1/3 of all completed suicides in the 18 to 24-year-old age group. 10% of all people diagnosed with borderline personality disorder will die by suicide. All right, so here are the 9 criteria, and we'll explain a little bit more about these in just a second. But the first one is what we consider frantic efforts to avoid real or imagined abandonment. 2 is a pattern of unstable and intense interpersonal relationships characterized by alternating between extremes of idealization and devaluation. The third is identity disturbance, which is markedly and persistently unstable self-image or sense of self. The fourth is impulsivity in at least 2 areas that are potentially damaging. It's like spending, sex, substance abuse, reckless driving, or binge eating. 5, recurrent suicidal behavior, gestures or threats, or self-mutilating behavior. 6, affective instability due to marked reactivity of mood. And this could include intense episodic dysphoria, irritability, or anxiety, usually lasting a few hours and only rarely more than a few days. Chronic feelings of emptiness, inappropriate, intense anger or difficulty controlling anger, and then transient stress-related paranoia or severe dissociative symptoms. So there's actually 256 different combination of these symptoms that could lead to a diagnosis of borderline personality disorder. And I say that because not all borderline personality disorder presents the same way. There are actually, I like to break down those 9 symptoms into 4 general symptom domains. And that is affective symptoms, which are all mood symptoms, impulsive symptoms, cognitive symptoms, and interpersonal symptoms. And we'll go through each of these, starting with affective symptoms. So frequent mood changes may appear to overlap with bipolar disorder, but there are several clear distinctions. And I say this because oftentimes patients with borderline personality disorder are misdiagnosed as having bipolar disorder, but there are clear differences and they are very important. Number 1, the duration of the fluctuations is shorter than in bipolar disorder. In bipolar disorder, mood changes must remain consistent and persist for at least 4 days for a hypomanic episode and 7 days for a manic episode. Number 2, in borderline personality disorder, there is a persistence of affective lability throughout life rather than during a discrete mood episode. In borderline personality disorder, symptoms gradually improve over time, over the course of someone's life. Whereas in bipolar disorder, they present in discrete episodes or periods lasting on average a couple of months for both mania and depression that cause the patients to present and function distinctly differently from their baseline. The third difference is mood reactivity. Mood symptoms of patients with borderline personality disorder are triggered by external events and are particularly sensitive to perceived rejection, failure, and abandonment. Impulsive symptoms. Between 60% and 78% of patients with BPD have shown suicidal behaviors, with more than 90% engaging in self-harm. Persistent cutting as a way of regulating emotions is a characteristic feature of this disorder, as are recurrent overdoses related to stressful events. Recurrent presentation to the ED for suicidality is suggestive of the diagnosis, with almost half of such patients meeting the diagnostic criteria for borderline personality disorder. Other common impulsive behaviors include gambling, spending, binge eating, sexual promiscuity, and substance abuse. Alcohol and substance abuse or dependence are seen in more than 50% of the patients with this disorder. Interpersonal symptoms. So we talked earlier about unstable relationships. This is one of the most important symptoms in making an accurate diagnosis of BPD, with studies reporting a sensitivity of 74% and a specificity of 87%. And don't get too bogged down by the difference between sensitivity and specificity. But the point here is that the vast majority of patients with borderline personality disorder report having unstable relationships. And actually less than half of women with the disorder marry, and even less have children. And I'm specifically saying women here because many of the studies that were done early on in borderline personality disorder were done in women, and it was thought to be a diagnosis primarily of women. We know that's not the case. Identity disturbance. This refers to frequent and suddenly changing goals, beliefs, vocational aspirations, and sexual identity, as well as a painful sense of incoherence. Patients often feel as if they need to assume the identity of others because they feel so insecure in their own identity. So some of the questions that I often ask when I'm screening a patient about symptoms of borderline personality disorder are, do you feel like you struggle to understand your place in the world? Borderline personality disorder patients often immediately identify with that. Do you feel like you have to change who you really are when you're around different groups of people? And again, patients with borderline personality disorder often lighten up immediately when I ask that question because it hits home. So cognitive symptoms. So 40 to 50% of patients with borderline personality disorder have brief periods of psychotic symptoms or dissociation. And the psychosis is very different than what you would see in an illness such as schizophrenia. Those with borderline personality disorder are much more likely to be short, circumscribed, and either based in reality or totally fantastic. For example, the world is against me, or I feel like everybody is against me. I feel like everybody is looking at me. I can't trust anyone, rather than extreme delusional content like the government or the FBI are tapping my phones and are after me. Can also have derealization, depersonalization, and illusions, and these can be difficult to differentiate from PTSD dissociation in patients that have a trauma history. And in fact, you can obviously have both. You can have PTSD and borderline personality disorder in those that do have a trauma history. All right. So I'm going to go through sort of the cycle of core psychopathology of what is happening and being experienced by somebody with borderline personality disorder as they become emotionally dysregulated. So the key problem for borderline personality disorder patients is interpersonal hypersensitivity. So the borderline personality disorder patient is easily triggered by rejection, criticism, and abandonment. And then this sense of disconnection is absolutely intolerable and triggers emotion dysregulation, which is anxiety, anger, and despair. It's rapid, it's intense, and it's prolonged. This emotion dysregulation eliminates clear thinking or the ability to wait it out. And so the BPD patient uses his or her limited options to end this painful dysregulated state. And this is what leads to the dramatic actions or problem behaviors that are self-destructive but temporarily soothing, or act to coerce reattachment. All right, so just some statistics about borderline personality disorder. It affects 1% of the general population, but we see it as 10% of all psychiatric outpatients. So all patients that present to outpatient behavioral health clinics, 10% meet the criteria for borderline personality disorder. 20% of patients on psychiatric inpatient units have borderline personality disorder. 6% of family medicine patients, so patients presenting to outpatient family medicine practices. The most common age at first presentation is in late adolescence. Most patients with the disorder are never identified in practice. And borderline personality disorder can be difficult to diagnose because of similarities to other conditions, particularly mood disorders, as we talked about earlier. So, as I said, the outpatient prevalence of borderline personality disorder is 10% in all ages, but we actually see that number is 22% in youth aged 15 to 25 years old. So whereas 10% of all outpatients in behavioral health meet the criteria for borderline personality disorder, the number is more than double in the 15 to 25-year-old age group. And if you remember, in inpatients, the prevalence is 20%. So 20% of all psychiatric inpatients have borderline personality disorder, but that number actually rises to 42% in young adults. And I ran a young adult inpatient unit for 4 years earlier in my career. And I can tell you with full confidence that absolutely 42% of patients in this young adult age range that get psychiatrically hospitalized meet the criteria for borderline personality disorder. It's the most common presenting illness in this population, more common than schizophrenia, more common than bipolar disorder, more common than major depressive disorder. We talked about these stats earlier, but I think it's worth repeating that borderline personality disorder accounts for at least 500,000 visits to the United States each year to the emergency department in the US each year. There is a 10% lifetime rate of completed suicide. The incidence of suicide attempts amongst patients with borderline personality disorder is highest amongst those in their 20s. The mean number of lifetime suicide attempts is 3.4. Suicide occurs and ends in death once per 23 attempts, and 33% of all transitional age youth suicides age 18 to 24 occur in patients with borderline personality disorder. So I put this slide here because obviously a lot of the suicide attempts in borderline personality disorder are impulsive, but suicide is final. So a lot of the times I will interview patients even after severe life-threatening suicide attempts where they may have been in the ICU, hospitalized, intubated, and they're so happy that they are alive and survived their suicide attempt. But unfortunately, sometimes they don't survive the attempt. Okay, so the understanding of borderline personality disorder by clinicians has changed over the years. In the 1970s, it was there was a lot of blame put on families that somehow it's the family's fault that a patient has borderline personality disorder. In the 1980s, it was really sort of the model shifted to thinking that this is really a diagnosis of trauma. In the early 2000s and into the mid 2000s, really the thought was that this is a genetic illness. And the way that we understand it now is through an epigenetic process, which means, like most of our conditions, it's a combination of genetics and lived experiences. But we do want to point out that there is a significant genetic component to borderline personality disorder. In fact, there's a 55% contribution of genetics, which is even more so than major depressive disorder, panic disorder, and PTSD. But below the sort of the three areas of psychiatric illnesses that we know have the highest rates of heritability, which are schizophrenia, bipolar disorder, and ADHD. Risk markers for borderline personality disorder. So obviously, if someone is born with borderline personality disorder in their immediate relatives, that adds risk. What we know is that if we look back to early, even the first 6 months of someone's youth in retrospective studies, that there is more likely to be disorganized attachment styles, hypersensitivity or reactivity, and difficulty self-soothing. And then in childhood, ages 2 to 10 years old, when we look back, there's reports of higher rates of parental separations, losses, divorce, exclusive friendships. So patients that have trouble making more than one friend, they kind of have one friend that they identify. Parentification, so when children are sort of forced or acting in the caretaker role. And then we also see a lot of comorbidity with patients who are diagnosed with ADHD and oppositional defiant disorder. All right, so childhood trauma in borderline personality disorder. This is a complicated relationship. We do know that 70% of patients with borderline personality disorder do have some trauma history, with sexual abuse most specific and neglect most prevalent. Most sexual abuse is not incest. But we also know that other personality disorders and other psychiatric disorders have equal levels of exposure to trauma. And we also know that 50% of patients with trauma develop without psychiatric consequences. So it's complicated in a couple of ways, because 50% of patients with trauma don't end up having any illnesses. And 30% of patients who have borderline personality disorder have no trauma history. So trauma can be contributory, but it's certainly not fully causal. All right, I'm going to skip over that slide. The point of that slide is just to say that there is a lot of overlap between borderline personality disorder and PTSD, and sometimes it can be really difficult clinically to distinguish between the two diagnoses, and requires a lot of skill on the clinician to really tease out the differences. Okay, so the first step in the proper diagnosis, a proper treatment of borderline personality disorder, is to make the formal diagnosis, to document it, and to provide psychoeducation to patients and families. Borderline personality disorder is billable as a primary diagnosis. Historically, there were times when it wasn't, and so clinicians would give diagnoses like mood disorder, NOS, or depression unspecified, but it's a billable diagnosis. And so that should not be a barrier to getting the formal diagnosis. We know that psychoeducation alone decreases impulsivity, hopelessness, and unstable relationships over the next 12 weeks. So when I'm teaching medical students and residents and other folks, I really emphasize that it is important that when you diagnose borderline personality disorder, you need to explain what it is and talk about it with patients and with families. And there are really 4 elements of psychoeducation. There's making the diagnosis and giving the diagnosis to the patient. There's explaining the etiology. There's explaining the course of the illness and the prognosis. And then there's explaining the treatment. So I often will say something to a patient such as, well, let me take a step back. There is tremendous variation amongst patients in their understanding of what borderline personality disorder is, especially in college students and teenagers right now. More are aware of borderline personality disorder than ever have been historically, partly because there's a lot more information going out on social media, even NAMI doing a great job of sort of getting the word out. There's been a lot of TV shows and other stuff in the media, famous people that have come out and talked about having borderline personality disorder. So there's more of an understanding of borderline personality disorder than there was historically. So oftentimes when I'm giving a diagnosis of borderline personality disorder, the first question I ask is, have you ever heard of borderline personality disorder? And I get such a wide range of people who are like, no, what's that? Or isn't that the same thing as bipolar disorder? To patients who really understand what it is. And oftentimes they'll be like, yes, I actually think I have that. I looked it up. All of the symptoms really make sense to me. Finally, somebody's telling me I have it. I thought I've had this all along. So it's important for me, just like when I'm doing any education, to really understand the knowledge of the audience before I begin the education. So I'll often say something like, individuals suffering from borderline personality disorder are born with a genetic predisposition to be very sensitive to signs of rejection and to be emotional, and they have low frustration tolerance. That's sort of my nutshell kind of psychoeducation statement that I'll make. And obviously I'll go into more information as we go along. I then actually sit with them and go through on a chalkboard or a whiteboard or something, or even a piece of paper, all of the 9 symptoms of borderline personality disorder. And we will sort of check off together the symptoms that we feel like apply to them, using their language and the examples that they've already told me about in their life, right? So in the patient that I talked about earlier, Allison, right, we would check off in impulsivity, her 12 sexual partners over the last year. Would check off her fears of abandonment. We'd check off the fact that she has mood swings. We would check off the fact that she struggles with her identity and sense of self. We would check off the fact that she has a history of self-harm, right? So as you're sort of going through this with the patient, they're sort of like, wow, these symptoms really do speak to me. They really do make sense to me. This diagnosis is more closely representative of what I've been experiencing than anything else that I've ever been told I have. So you're getting the immediate buy-in, which is extremely important, right? And so then they want to know, well, why me? Why do I have this diagnosis? And so I stress the biology, just like I did earlier, that there is a 55% heritability. I talk about sort of 2 areas of the brain that we know are impacted and different in patients with borderline personality disorder. There's an area of the brain in the front of the brain called the prefrontal cortex that is sort of the brakes of the brain that sort of causes you to stop and think before you act. And we know that for some reason or another, things are just not firing away in that area of the brain to the extent that we wish that they were. And then there's another area of the brain called the amygdala, which is kind of the emotion center of the brain. And we know that that area is just a little bit on overdrive, right? So here we have 2 parts of the brain. We have the emotion center on overdrive and the brakes just not quite working the way that we would, firing the way that we would want them to be. So that often makes a lot of sense to patients. It's simple biology, but I find that to be really helpful. And then I'll say something to the effect of, while some borderline patients have a clear traumatic experiences, including perhaps even neglecting or abusive families, in many cases, there is not a traumatic environment, and siblings and even twins often report a more positive perception about caregiving. Moreover, borderline personality disorder can develop without traumatic experiences, and traumatic experiences don't always lead to borderline personality disorder. And I highlight this point because I think this is extremely important. The exact causes of the disorder still need to be identified. What is clear is that neither borderline patients nor their parents are responsible for the disorder. We are not going to allow patients with borderline personality disorder to blame others for their illness, especially their parents, because that is not helpful. All right. I then talk about clinical course, conveying, cautious optimism. 20% of borderline personality disorder patients do have remission in a year. 50% remit in 2 years. 85% remit in 10 years. And after they remit, there's only a 15% relapse. And that if they adhere to effective treatment, go to therapy as they're supposed to, these numbers will be even higher. But along with that optimism, you have to sort of highlight the caution, which is that improvement in social function is less frequent, and that significantly diminished functioning in schoolwork and relationships still persist in many patients at 10 years. And even though they may remit, it doesn't mean that all of these symptoms go away. They will still continue to struggle with them. It just means that they're not necessarily having 5 of the 9 symptoms at any given time. All right, I then talk about treatment. There are multiple forms of empirically validated treatment for borderline personality disorder. A lot of people have heard about DBT, or dialectical behavioral therapy, which is one of the many empirically validated treatments. It's a wonderful treatment, but it's not available to everyone for a number of reasons. It requires a lot of training for the therapists, and in certain areas, there just aren't enough therapists to meet the needs of the population. But there are other really great treatments available for people with borderline personality disorder. All of these validated treatments decrease self-harm, anger, depression, and use of hospitals, emergency departments, and medications. And the treatments usually require 1 to 3 hours per week for a year or more by therapists with extensive training and ongoing supervision. This is not, recovery in borderline personality disorder is not a passive process. It requires work. And the patients that are willing, and the families that are willing to put in the work, are the ones that get better. All right. There are really sort of 3 overarching goals of treatment. Susie, how am I doing on time? I don't have a clock up right here. How are we doing?
It is 7:45.
Perfect. Great. So there are 3 main overarching goals of treatment. And I'm going to talk a little bit more about what these are. But one is what we call create a holding environment. 2 is to help the patient expand reflective thinking. And 3, to help them build a life worth living. And these hold true across all different types of treatments for borderline personality disorder. So what is a holding environment? This is an interpersonal setting that is more supportive, reliable, empathic, responsive, and realistic. So we'll talk a little bit more about that next when we talk about the roles of families and what they can do to help support their loved ones. It's modeled on an old psychotherapist named Wittencott. It's a model of good enough parenting. The idea is that the holding environment starts with the therapeutic relationship. So me as a clinician, I'm first going to create an interpersonal setting that is more supportive, reliable, empathic, and responsive than a patient may be used to or accustomed to being treated by. And then the goal is to generalize that to life outside of therapy, including relationships with others, and family and friends and loved ones. And then lastly, the goal is to sort of internalize this holding to a sense of self, right? So the patient themselves is more supportive, empathic, and responsive towards themselves. And this isn't easy, by the way. This could take years and years of treatment. And this is a much simplified sort of description of this. But I think the concept of a holding environment is an important one for people to understand. Number 2, we want to expand reflective thinking, right? So we call this an observing ego, or in DBT, they call it a wise mind. And essentially, right, this is more prefrontal cortex and less amygdala. These are sort of the areas that we talked about earlier, right? More of this breaks and less of the acting impulsively and on emotion. So we want to build mindfulness skills, right? Help patients observe, describe, what am I experiencing? We want to build mentalization skills, including empathy. What is another person experiencing? Other sort of helping patients to think outside of themselves. We want to reduce emotional reactivity and impulsivity, expanding the space between when you feel and when you act, right? Sort of pausing with the feel, identifying it, and sort of helping patients build skills and use all different types of skills and models and understanding to help them go from feeling to acting. And that's where the distress tolerance skills come into play to help them buy the time. And really expand logical thinking, right? We use things called chain analysis to go back and break down, you know, how did A lead to B, lead to C, lead to D? What could we have done along the way to help disrupt that, that chain of events? Helping patients sort of plan ahead, right? If we know they're going to be going into a stressful conversation, if we know that they're going into finals week, if we know that they're having trouble with their relationship and their loved one, and they're going to, you know, have a breakup, right? We want them to sort of think ahead and plan ahead and anticipate the consequences so that they can prepare for those events rather than acting on emotion in the moments. Again, a lot of this stuff seems very simple, but can take many, many, many years or months in treatment to really to hone in. All right. And then the last one is we want patients to ultimately build a life worth living, right? The goal is to shift the focus from continual crisis management to have them articulate realistic life goals and build skills and stabilizing factors into their life, structure, expectations and accountability, work or school, volunteering, part-time or full-time paid work, support groups, and reliable relationships. Just really briefly, I'm not going to go into medicines too much here, but the take home is that there have been about 30 randomized control studies for lots of different types of medications, including antipsychotics, antidepressants, mood stabilizers. Usually the studies are not great. They have small sample sizes. The studies are for a limited duration. So one of the problems is that we haven't really had great studies, partly because pharma-sponsored research is limited by fears of suicide in this population. And so they've limited the studies that they're doing in this population. But ultimately, no medication has been uniformly or dramatically found to be significantly helpful. And we don't have any FDA-approved medications for this condition. And we know that actually, the more medication someone is on with borderline personality disorder, the less likely they are to improve. And that doesn't mean that there isn't a role for medicines. I'm a psychiatrist. I prescribe medicines all the time. I prescribe to patients in borderline personality disorder, but we have to really sort of temper expectations and not expect medications to be the solve-all. And I tell this to patients, again, this goes back to patients are going to need to work in their recovery. There isn't a magic pill that they're going to just be able to take and feel immediately better. Medicines may help, but it's not going to solve everything. So the strategies that I use when I'm working with a patient talking about medications is I'm going to temper high expectations. I'm going to emphasize the need for collaboration. I encourage the patient to read about whatever medications that they're on. I give them reading. And essentially the point here is that I'm enlisting the patient as an ally in the process, right? I want them to think of it as an empirical process where we learn together whether or what medications are actually helpful. We want to then stress the necessity for responsible usage to evaluate effectiveness. We are never going to know if the medicine's effective if someone's only taking it twice a week and they're supposed to be taking it every day. I'm not proactive with prescribing. I really only prescribe if the patient is requesting the medication because they really feel that they need to be on something, or if I feel that they're severely distressed. And then we medicate specific symptoms if necessary. For example, SSRIs, which are a class of antidepressants, or some mood stabilizers can help with some of the affective or mood symptoms. Antipsychotics can help with some of the cognitive symptoms. And then lastly, it's important that we obviously treat co-occurring mental health disorders, such as major depressive disorder, generalized anxiety disorder, or PTSD. All right, so how do we help Allison's loved ones help her? So I have a few points here. If you remember, I'm going to actually go back and reread the last line of my presentation of Allison. When asked about her parents, she says, in quotes, "They are nice people. They work hard and want to give me a good life, but they don't get me at all. They're old school and just tell me to snap out of it and stop being a drama queen. My mom yelled at me when I got hospitalized because it was embarrassing to the family." So if there's any slide, I hope that you as families can sort of take home with you and internalize, it's this slide. And the key points here are that you need to, or you're most helpful when you are able to identify her pain and suffering, right? So an example of a quote that I would tell parents to use are, "I know that you are hurting right now, and it feels like nothing can help." Next step, identify that her pain and suffering was not a choice. "I know that you would never choose to feel this way. You don't deserve this. It's not fair," right? Nobody would wake up one day and say, "Wow, I want to be in emotional pain today. I want to hurt myself. I want to be suffering," right? So being able to sort of identify that and repeat that and explain that you understand that back to your loved one can be so powerful. I'm going to repeat that again. "I know that you would never choose to feel this way. You don't deserve this. It's not fair." Third bullet point, express an interest in understanding more about her emotional pain. So in quotes, right? "I want to better understand what you're feeling. Let's talk more about it. Tell me what it's like for you." Next bullet point, provide unconditional love. "I love you no matter what. I will always be here for you," right? Remember that fears of abandonment are one of the symptoms. Patients understand that their problem behaviors can be off-putting to other people, and yet they sometimes can't help it, but they fear that they're going to lose you. So be reassuring them that "I love you no matter what, and I will always be here for you" is extremely powerful. Next step is be a part of her recovery team, right? We are in this together versus "you need to get some help," or "you need help with this," or "you've got a problem, go deal with it," right? We are in this together. Ask, "How can I help?" We want to avoid judgmental language such as drama queen or dramatic or "you're just difficult" or "you're a problem" or "get over it" or any of those types of judgmental language. Encourage hard work in her recovery and validate her efforts. And then lastly, and is extremely importantly, we need to be talking openly with our loved ones with borderline personality disorder about their suicidal thoughts. Are you having suicidal thoughts? You need to let me know when you are. Help is out there. Let's work through this together. So those are my slides. I'm just going to end with a quote from John Gunderson, who's a psychiatrist who is really one of the founders of different treatment modalities for borderline personality disorder, who often said stable environment goes back and forth, leading to stable self. So stable environment leads to stable self leads to a stable environment, and future happiness depends on finding strong and enduring partners and vocations. I have a bunch of resources that I will make sure that I send to Susie and the team to get out to you. So these are websites, right? It includes the NAMI website, the NIMH website, DBT, self-help, borderline personality disorder central. There's a bunch of great websites here that I will pass along. I also have books. I have both books where you can learn about the condition, and these are for patients and for family members. And then I also have first-person accounts. So people who have lived with the disorder talking about the condition, which again could be very powerful for those who have borderline personality disorder. because they can understand and learn, again, that they're not the only ones who are experiencing it by reading and learning about other people's conditions. So it looks like I am right on time, 7:57. So we are gonna, I guess, wrap up the slide portion here. And Susie, I think you're gonna open it up to questions.
Thank you. Yes, that's great. First, I want to thank you. That was a lot of information, a lot of slides. You did great staying on schedule, and I'm sure everybody in the audience has learned quite a bit. I would, in my own point, would be that Allison's parents need to come to a family-to-family class at NAMI in order to, mellow their sense that they're alone and learn some of those communication skills. So we can help teach the family some of that as we try to do that in our classes. And now we'd love to take questions. So anything you have, put it in the chat and we'll get to it. I see a couple have come through. People are recommending other books and stuff like that, but let's get
Great.
questions.
I love that. And by the way, I mean, I'm open to additional, I'm constantly wanting to learn about different books and things that I could read for myself to better understand my own patients, but also to be able to recommend back to patients and families. So that's fantastic.
That learning attitude is wonderful, Dr. Berlin. I'm not surprised. So one book that was mentioned, I'll read it here. Another book for lived life with BPD is named Rough Magic. Somebody suggests here. That's more for you because people can read the chat. I know you don't have the time right now to do that. Somebody had asked, how can we get, let's see, I have to move the chat here. I apologize. Somebody just added something. How can we help parents break through clinical resistance to involve us in the treatment team?
Yeah, look, I think that's a great question, right? I mean, especially with young adults, they're often wanting to sort of deal with this on their own. I think that just emphasizing to your loved one, whether it's a child or a partner or a parent or anybody that's important in your life, that I want to be part of your team because I want to be able to help you. I know that when you're in crisis, I want you to be able to come to me and I want to have the skills and knowledge that I need to be able to help you in those moments. And I feel like I could be most helpful to you if I'm part of your treatment. But at the end of the day, you want to just reiterate that and that you love them and you care about them and you want to be there for them in the best way possible. And you think that by being in their treatment, you'll learn things that can help them. But you don't want to push at the same time. I mean, I think you want to, some patients are not ready. And so you might just say something like, look, if you're not ready to involve me in your care now, that's understandable. But whenever you're ready, I'm ready to be there for you as well.
Thank you. Is there a good resource for finding clinicians who have experience with BPD, such as psychiatrists or psychologists?
I don't know the best way to answer that question. I think there's lots of different ways that people find therapists or providers. Obviously you all know that it's one of the challenges in our area is that there are lots of providers out there who don't accept insurance. And so that becomes a barrier. I think that, most of the academic medical centers have folks who have expertise in borderline personality disorder. I think that, here at Stanford Health, we're growing our outpatient center and we're, recruiting people who we believe have expertise in this disorder as well. But I think it's a tough question. I mean, obviously there's things like Psychology Today that you could look into. You could talk to your primary care doc. You can talk to other family and friends. Again, going back to NAMI, I would rely on the other loved ones of people who have suffered and have struggled and ask them where they've gotten their help and if they've found anybody who they think is helpful. But it's really, I don't know of one sort of place where you can go and say, here's your list of, 22 people in Fairfield County that accept insurance, that have great expertise in working with this illness.
As always, it's difficult.
Yeah.
Here's a question. Situation of a 16-year-old male who has difficulty settling down and falling to sleep since very early years. Does sleep figure into the difficulty with emotional dysregulation when other aspects appear to align with BPD?
Yeah, all I'll say is that, there are so many different factors that make somebody with borderline personality disorder more susceptible to becoming emotionally dysregulated. Not eating well, right? If you're hungry, if you're tired, if you are, those are just physical things, right? Hungry, tired, in pain, right? If you're going through like a medical illness or a condition, or you have a headache, if you're using substances and possibly withdrawing from them, or if people are drinking the night before, then the morning after they feel hungover, that's going to lower someone's threshold for becoming emotionally dysregulated. So there are all different types of things, not to mention things like it's finals week, or my parents are going through a divorce, or there are just so many different things in people's lives that can lower the threshold. We know that in borderline personality disorder, like usually like little things are starting to build up, and then at some point they cross a threshold, and that's when they sort of race up, and that's when you go from 0 to 100, and that's when the problem behaviors, often like cutting, are happening. So really trying to diminish and limit as much of this sort of buildup as possible. And part of that is getting good sleep and getting healthy sleep.
Makes sense. A question from before the presentation, so it's not in the chat. Let's get a few more in the chat if there are questions out there while we have Dr. Berlin's time. But one that I had ahead of time, with BPD showing up on shows and more recently, becoming more publicly discussed as a diagnosis. Have you found some older people coming into you that say, I'm 40, I'm 60, and I think I've had this all my life?
So because my area of expertise is college mental health, most of the referrals to me are younger people. I have some patients that are older, but truthfully, that's not something that I've experienced. I'm sure it's happened, right? I'm sure there are people who have had borderline personality disorder their whole adult life and have, either been misdiagnosed or just not diagnosed, and they never knew what they had, and they're finally now, because it's becoming more understood in the in society, that they're finally realizing, wow, I've had this all along. And that's also like, kind of a hard thing to learn, right? It's like, wow, I've had this for 40 years. And if I knew that there was treatments, if I knew about this, I would have been able to possibly treat it differently. So I'm sure people have had that experience. And again, that could go either way. People could be really upset that they're like, wow, I've gone my whole life. I should have known this so long ago. Or there could be people that finally, like, I don't care. I'm 60, I'm 70, I'm 80. I finally learned that I have this. Finally, there's some, I can understand what's been going on. So the answer is, I'm sure that's happening, but B, partly because of the population that I treat mostly, I'm not seeing that as much in my practice.
And another one that came up earlier, it seems scary to bring up suicidality with your loved one. And why is that so important?
I would say that, so first of all, there's a myth out there that talking to a patient or a loved one, right? So even there are clinicians who are afraid to talk about suicide with patients. There are parents, there are brothers, sisters who are just not afraid to talk about it because they think somehow that the conversation is going to increase the likelihood that they would have a suicide attempt, right? That somehow it's going to trigger them. That is a myth. And I can promise you, there is no patient that I've ever asked about suicide that said, you know what, I haven't thought about that, but that's a good idea. I'm going to go act on it. It just doesn't happen. And the same is even true when I start to ask patients about specific methods, right? There's ideas of like, there's concern out there that, oh, you don't want to plant the seeds. That's nonsense. I mean, I ask patients, have you thought about overdosing? Have you thought about hanging yourself? Have you thought about all different types of things? And again, there's nobody who said, you know what, I hadn't thought about that, but now that you ask about that, I'm going to go do it. It just does not happen. And in fact, it's often an enormous relief for patients who are struggling with suicidal thoughts that someone is finally willing to talk about it in a way that's non-judgmental. And like you're giving them permission to talk about these really dark things that they're experiencing that they've held inside for a really long time. So my experience with it is that it's a hard thing to talk about, but it's often harder for the person asking about it than it is for the patient.
And there are programs even for parents. I've taken it, mental health first aid, where they make you try it out for the first time, bringing it up. And, it's hard, but it's less hard the next time. We're getting lots of thank yous to you in the chat, all very nice. Does frequent lying figure into the diagnosis of BPD?
So not in particular. I mean, that's not a diagnostic criteria. But I think that folks with borderline personality disorder come up with all different types of strategies to meet their immediate needs when they're in distress, even if they are not great long-term coping skills. And so, for example, I treated a patient who was in a support group that I was leading for patients with borderline personality disorder, who had borderline personality disorder, who feigned a cancer diagnosis to the group, right? Lied about a cancer diagnosis to the group because she felt that the group members weren't really respecting her illness and didn't feel like she was being understood. And she felt that in that moment, she needed the support and the empathy of other people. So she lied. And that was a skill, a maladaptive coping skill. So it's not a diagnostic criteria, but it can happen in some patients with borderline personality disorder in various ways. It can happen in patients with lots of different disorders.
Thank you. We have Denise Festudia here in the chat. She is the clinical director at Laurel House, and she said they have many support education programs. They're based in Stanford and help young adults in Lower Fairfield County return to college. They also have free website, which is www.rtor.org. And it does have a listing of local mental health resources, programs, and therapists that can be helpful to find somebody. We often recommend that in our NAMI support groups too. So thank you for that, Denise. Is BPD generally associated with higher intelligence? 3 questions here: intelligence, manipulation, and outsmarting. Someone has asked that.
The answer to that is no. I mean, there's no IQ association with borderline personality disorder, or, again, like some patients have developed maladaptive interpersonal techniques, which can be, lying, manipulation, etc. But I don't think that they're better at it necessarily than other people. They may just have more experience using it.
As you pointed out, there are 256 combinations
Correct.
of those.
Correct.
So you could get a mixture of most anything, I suppose. It's very individual. And in this diagnosis, I understand it's so individual, so it really makes the diagnosis tough. Here we have Could you talk to the relation between ADHD and BPD? And if one is not treated, does it lead to the other neurodivergency?
Yeah, so it's a complicated question. I mean, obviously you could have BPD without ADHD, you could have ADHD without BPD, you could have them both. I think what's challenging, the most challenging thing about people that have both, especially if the ADHD is undertreated, is that impulsivity is a criteria of both of them. And so you're getting sort of, you're getting a double dose, if you will, of impulsivity, which can be really challenging. There are also, untreated ADHD, can lead to other, especially in college students, can lead to difficulty with academics, right? And so if you're struggling academically, again, your threshold can be lower, right? That can cause more distress, which can cause patients who have borderline personality disorder to be more reactive. And then patients with ADHD, sometimes when it's untreated, can also just like struggle in interpersonal relationships because they blurt things out. They could be perceived as annoying by other people. And so again, like that can be compounded in someone who has borderline personality disorder who's already struggling with interpersonal relationships. So I'd say that like the three sort of areas that can be most difficult in overlapping is the impulsivity, the interpersonal relationships, and the academics, and how that, and the stress from the academics and how that could be triggering.
That's helpful. Thank you. Let me see if another one popped in. I have to get over to my chat screen, and mostly we're getting thank yous, great answers, and great presentation. I think it's what we're getting. So, okay. Well, I don't believe I've missed a question. I hope I haven't. If somebody, well, here we get another one. Good. We still have some time left. What are your thoughts on using marijuana to cope with BPD, anxiety, ADHD?
So there are three separate questions. Look, I generally, as a rule, do not think that marijuana is helpful at treating any psychiatric condition. I think that there are people who disagree with me. There are people who have these conditions who swear, that they have an anxiety disorder, that it's the only thing that helps them calm down at night and go to sleep. And, at the end of the day, you are in charge of the decisions that you make and how it may or may not impact you. But I think that most often, even though the cannabis could help you feel more relaxed or more calm in the moment, it increases the overall underlying anxiety, and makes you more susceptible to panic attacks and other symptoms of anxiety. I think the same is true of borderline personality disorder. I think it's, I think that if you're self-medicating, you're often avoiding using the harder skills to use that you lose in treatment. And it's sort of, you're kind of avoiding doing the harder work that I think tends to be more impactful and more successful at treating your symptoms. You're kind of kicking the can down the road rather than addressing it. But again, that's I think every individual person is different, and their situations are different. And this goes back to the 256 different types of patients with borderline personality disorder. If a patient really feels that it works for them and it helps them and they're using it, who am I to tell them not to use it anymore? I mean, I just sort of weigh the pros and cons, and ultimately they make their own decisions.
Makes sense. Here's a question. What criteria will mean someone with BPD is able to remit?
Oh, I mean, any of the criteria could lead to, you can remit in any of the criteria, right? I have patients who, for example, have gone years without self-harming. And so and to the point where they no longer even have urges or thoughts to self-harm. So they've remitted from that particular criteria. I have patients that have, really found a romantic partner that they love and trust and have a great, healthy relationship with. And so the interpersonal symptoms of devaluation, of sort of turbulence in that relationship, idealizations, evaluation are no longer really there, and the abandonment fears are not really there anymore. So I think you can remit on any of the symptoms. Remission for the illness would really just mean that you no longer are actively experiencing 5 of the 9 symptoms at any given time.
That makes sense. Okay. Anything more? Thank you is what's come through recently to you. So.
All right, well, let's wrap up. I really appreciate you all being here and being so engaged with the questions. And thanks to NAMI for hosting me and for inviting me to present today.
Thank you, everybody, for joining us. And Dr. Berlin, thank you mostly.
Thanks, everybody.
Good night.